Friday. This is Karina Hill in behalf of the Florida Alcohol and Drug Abuse Association. We want to welcome you to today's webinar entitled Strengthening the Therapeutic Alliance with Yaritza, Semenuk. And we just have a couple of housekeeping issues to go over. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Just wanted to let you know that everyone is in a listen-only mode and will only be able to view your name. If you have questions, please send them to myself and the presenter by using the Q&A or chat panel. The button to open the panel is usually located on the upper right side of your monitor. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it as well to receive a certificate of attendance. And also just wanted to let you know quickly that we do have a few videos, and if you're calling in through the phone, unless you have your computer hooked up to speakers, you will not be able to hear the video. But again, in order to get your certificate of attendance, you need to be able to view and hear the video. The recording and materials in today's presentation will be available on the FADA website within 30 business days. You will need to find the information in our resource training center. The archive video displays what looks like to be an error message, but it's only a delay buffer, so just ignore it, hit play, and enjoy. And again, that's on our website in the Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Wednesday, June the 24th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx does monitor the arrival and departure of all attendees, and it provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter, Yaritza Semenuk. She's the Clinical Director for the American Addiction Center in Hollywood, Florida. She has developed a mindfulness stress reduction program for veterans. She specializes in working with dual diagnosis individuals in detox, residential, and partial hospitalization settings by using evidence-based therapeutic interventions. Ms. Semenuk has an extensive clinical training in trauma-informed treatment and crisis intervention using various evidence-based treatments modalities, including MI, MIDR, ACT, and DBT. And with that being said, Yaritza, if you're ready, we can go ahead and get started.
I sure am. Can you hear me?
Yaritza, can you hear me?
I can hear you.
I can hear you as well.
Okay.
Are you able to hear me?
Yes.
Okay, perfect. All right, so welcome everybody. I'm super excited to be here and be a part of the presentation today. I look forward to reviewing and going over the Therapeutic Alliance and the importance of it as a clinician. So welcome everyone. Oh, I'm sorry, I went the wrong way. Okay, so I had to go a little bit backwards, I'm hoping. And Karina, are you on the line? Because it's not going to my next slide.
Okay, Yaritza, 1 second, please. Okay, I just moved it back over to you. You want to try it again?
I sure can.
Karina, I'm still seeing the introduction slides.
Yeah, that's allowing me to go through that, but unfortunately it's not allowing me to go through my slides.
Okay, how about now?
We're still seeing the introduction slides. Can you reshare her presentation?
Okay, just give me 1 second, please.
Sure. There we go.
So I just want to make sure that it's allowing me to go through them. Okay.
Are you able to see them now?
Yes, we can, and I'm able to go through them, which is helpful. And going page up and page down. So today we're going to talk a little bit about, a lot of it about the strengthening the Therapeutic Alliance. And the objectives are going to be...
Let me give her the control.
Okay. The importance of the relationship between the individual and the therapist. How to build and establish rapport with the individual to enable them to feel understood, valued, and supported. And also clinical skills that can strengthen the Therapeutic Alliance. Karina, I think I can still hear you in the background. So we'll review the impacts the relationship has on the therapeutic process and the importance of it. And it is very important to discuss about the trust, the willingness, and the openness that needs to be gained in order to have the client engage and invest in your modality. And then we'll also review like basic therapeutic skills that most of us are taught in school. We'll go over one modality today, and it will be a quick review on motivational interviewing. Motivational interviewing is often used in substance use. It's the number one that we do tend to use, and it's effective and it's evidence-based. So we'll take a quick review on that too, and how the skills actually apply to that. So the what? It goes way back. Freud, who was a psychoanalyst, initially conceptualized Therapeutic Alliance as a negative transference, but later considered the possibility of a beneficial attachment developing between the therapist and the individuals they serve, and not as a projection, which was what he first initially believed. Zetzel, who defines the Therapeutic Alliance as a non-neurotic and non-transferential relationship component established between the individual and the therapist. And so he was one of Freud's antecedents and one of the analysis that eventually established and stated the importance of the therapeutic rapport. So what is the Therapeutic Alliance, right? It's a cooperative working relationship between the client and the therapist, considered by many to be an essential aspect of successful therapy. I know that in school and often as clinicians, our modalities are important to us. I know that me specifically, I've been trained in EMDR and ACT therapy, which is one of my favorites, motivational interviewing, and DBT. But over the years and through my experience, what I've noticed is that if I don't have that rapport with the client and there's not a mutual trust, then the modalities really aren't that helpful because we need the clients to have that buy-in. So it's derived from the concept of psychoanalytic working alliance. The Therapeutic Alliance compromises bonds created by the therapist and the client, the goals and tasks. Bonds are constituted by core conditions of therapy, that client's attitudes towards the therapist and the therapist's style of relating to the client is a big piece to this. And I'll go through this a little bit more extensively coming up in our next slides, but what are our morals? What are our values? How are we mindful of those? How do we impose them even without knowing that? And so I think it's very important as a clinician to have your own knowledge of your own barriers, your own triggers, all of those things, because they can get in the way of the alliance. So goals are mutually negotiated, understood, agreed upon, and regularly reviewed aims of therapy, and tasks are the activities carried out by both the client and the therapist. So it's, again, I often have spoken to a lot of the clinicians that I supervise and are currently supervising, and we talk a lot about these, the power, the alignment, the shifts in power, and how to be mindful of that. So the Therapeutic Alliance is a collaboration and effective bond between a therapist and the individual. It's the development and continued maintenance of the therapeutic relationship as a primary component to facilitating the individual's change. The therapeutic relationship explores the thoughts, beliefs, feelings, experience, and needs of the individual. And essential qualities for developing an alliance with the individuals are trust, non-judgmental stance, and empathy. So here are some of the skills that we talk about that we see coming in as the importance of how to develop that trust with the client. Okay. So the Therapeutic Alliance significance catalyst for change, strong and healthy therapeutic relationship that facilitates the change between these two people, the therapist and the individual that they are serving. Therapy is a personal relationship that operates within the boundaries of a professional structure. The alliance builds a stronger foundation upon which the relationship rests. So again, this is just reinforcing the importance of the relationship. How is that relationship? The ups and downs, the triggers, the transference, the countertransference, and are we being mindful of that in our sessions? We have a level of awareness of our own triggers, of our own barriers. And I think it's super important for clinicians to do their own work individually so that they can understand what those look like and what the barriers can be for them. So factor, is the therapist more important or the therapy? It's the whole what came first, right? The chicken or the egg. There is considerable evidence that the Therapeutic Alliance may be more important factor than the type of psychotherapy in deciding a therapeutic outcome. So it goes back to that whole thing, like what's more important? Is it the modality that we use, or is it the relationship, our knowledge, our skills? And of course, I don't think, even with multiple studies, we can narrow down, hey, this is definitely what it is for sure. But most of us who are clinicians understand that if we do not have that therapeutic rapport, then we're not going to be able to establish that alliance. So I'm just going to review a couple of studies that supports this notion. Common factors associated with psychotherapy outcomes is like extra therapeutic, which is 40%, right? When I first was reviewing this, I was thinking, wow, 40% like appears to be pretty high. And then I thought about that. And as a DBT therapist, one of the things that we had to do is not only be available for our clients in a session, but also outside a session. And that would be like extra therapeutic support. So what would that look like? If a client in DBT modality wants to text you, reach out, or they're experiencing some mood dysregulation or, fleeting suicidal thoughts, then as a DBT therapist, we are responsible to respond to that. We answer the phones no matter what times. And of course, we have to practice boundaries, right? So these are all the things that we talk about before, we establish our therapy. But it is very interesting that this 40% was greater than anything else. So what else does that look like? Homework giving outside of it. The cost, like what are the costs for me to go see a therapist? Is my insurance covering it? And then like the willingness. Think about once you enter into therapy and you're willing to do that, the question is then going to be like, okay, if I'm willing, how open-minded is somebody when they know that they already have that willingness to come into session? So that's a big piece of that too, because when we come in with an open-minded approach, then their willingness to change and to listen and to establish is going to be there. The Therapeutic Alliance is then 30%. So here's, compared to the therapy model at 15%. So again, and I know for me in school, like the therapy model was highly emphasized, and they talked a lot about, once you graduate school to choose one or be proficient at one, expert in one, those things were emphasized. But it's really fascinating that the rapport that you have and the relationship is still 30%. And then the placebo effect, which I thought was interesting as well, is I think that's, again, coming into the session saying, hey, I'm going to come in and I'm going to do some work and I'm going to have some willingness to change. And, this is therapy. It worked. So there's that effect. And it's at 15%. So here are some treatment outcomes. Percent of improvement in psychotherapy, individuals as a function of therapeutic factors. So again, extra therapeutic factors, here you see it, in the pie form, it's 40%. Client therapist factors, 30%. Expectancy, 50%, and that is that placebo effect. And then again, here's the modalities at 15%. So as I was studying this and doing my own research, I found it really fascinating that only 15% is based on a modality. So the studies, this viewpoint was most recently confirmed by Strupp 2001, showed that the outcome of a psychotherapeutic process is often influenced by a so-called non-specific factors, namely the personal characteristics of the therapist and the positive feelings that arise in the individual. So this goes back to relationship, unconditional positive regard, which we're going to review, genuineness, the difference between empathy and sympathy. Clients are reading us just like we're reading them. When I do supervision for a lot of my therapists, I often explain to them, like, if the interview is going both ways in that room, they're trying to figure out your level of genuineness, your level of interest, and your level of being able to take a non-judgmental stance. It's very important. So it's just as we're seeing clients, they're seeing us. Feelings which can lead to the creation of a positive therapeutic climate from an emotional and interpersonal perspective. Studies of the efficacy of the Therapeutic Alliance in a multitude of clinical samples. So here we're going to talk a little bit about, does the therapeutic relationship make a difference, whether it's substance use, whether it's a personality disorder, whether it's a mood disorder, grief and loss bereavement, or substance use-related disorders, and across a range of treatment methods, 12-step medication, psychotherapy, and cognitive behavioral therapy. And even the levels of care, does it matter? Does the relationship matter at detox versus residential, outpatient, and aftercare? And all of these all of the Therapeutic Alliance studies have led to saying, hey, you know what, regardless of the level of care and regardless of, whether it's eating disorder or the population that you are treating, it all remains the same. In these wide-ranging studies of diverse problems and therapies, researchers have found the Therapeutic Alliance is a moderate but consistent predictor of outcomes. So for substance abuse, one recent study found improving the quality of the Therapeutic Alliance during treatment contributes to a significant reduction and alcohol use. Another review concluded the content or even model of therapy has little effect on improvement of substance-related outcomes. So this was a little mind-baffling for me, just to be honest, because I was like, wow, like the modality that I use has little impact on substance use, related outcomes. I thought that was rather fascinating. And it just reinforced, when I go into sessions and I have a client, my first thought is like, how can I capture them? How can we relate? What is it that I can find that we have common ground in? Something easy to start that conversation. So especially the capacity for empathy can have significant effects. More recent meta-analysis of studies examining the linkage between alliance and outcomes in both adult and youth have confirmed these results and also indicated that the quality of the alliance was more predictive of positive outcomes in the type of intervention, which is just reinforcing what I was saying. But there was slightly different results in youth psychotherapy. And I really didn't dig into, the why behind that, because I was pretty curious that, okay, so does the modality have, a different impact in youth, or is it more of a family systems approach? So, that, I was somewhat curious about that piece of it. I found it interesting. Some common factors, treatment outcomes. Common factors including the individual-therapist relationship are significant to the individual's improvements and outcome for 30% of the variance in individuals' outcome. So I thought that, again, reinforces the importance of the relationship. It is difficult to differentiate between therapist variables such as interpersonal style or personal attributes, facilitative conditions. So, what this really means is, yes, the therapeutic alliance is very important, but what they couldn't differentiate is what about it, right? Was it my communication skills? Was it that culturally we were on the same page and there was a clear level of understanding? Was it the warmth, the genuineness? I was treating a client a couple years ago, and the client was very guarded. And he would come into my office and he would sit there, and I honestly felt like I was pulling teeth to get him to conversate with me. And when I sense those barriers, sometimes I'll even say like, hey, what I'm experiencing, I'm struggling. Are you feeling the same way? Like, I just want to make sure we're on the same page. Or, I sense that like it's hard for me to, just have you tell. Is it just difficult to tell your story? Is there something that maybe, I'm doing that makes it difficult? And I have a very open discussion with my clients in that sense, direct approach in that manner, because I like to remove barriers. And so he's like, no, I'm just, typically quiet, and it just takes a lot for me to open up. And even through the whole process that, I was questioning, I'm like, did I remove the barriers? Was the transference? Was he struggling with something about it? And when he left, he was like, hey, I'm, super thankful. Yaritza, I appreciate all you've done for me. And I'm like, okay, like I'm thinking to myself, like, I really hope I did something. And then a year later, he stops by to visit. And he comes in and he's like, oh my God, it's so nice to see you. And I'm like, hi, how are you doing? It's great to see you. And he says to me, whenever I come into this office, it was so warm. It was the place that I could just sit here and be me, no judgment. And I looked at him like, this office is that warm to you? He said, you have no idea. And it was just fascinating to me because I thought, here is a person, and I'm thinking, hey, like, is this really working? And yet, like, just the presence of warmth in my office and his ability to be, to feel non-judged had that impact on our relationship and the outcome. And these concepts are not mutually exclusive or distinct, but are independent. So does anybody have any questions thus far on any of the studies or anything that we reviewed? And I know I see one question from Alice. She asked the difference between LMCH and what does that stand for? And it was just a mix-up in the letters. Now I'm LMHC. So here's some key ideas in the Therapeutic Alliance. So the difference between therapeutic and non-therapeutic is, as therapists, we obviously give hope to people who are feeling hopelessness. We are, the scale of genuineness versus disingenuousness, caring versus self-centeredness. And, as I'm going through some of these and I think of genuineness versus disingenuous, I can't even say the word. What I wanted to talk a little bit about this is, especially in adolescence, sometimes as clinicians, when I tell my therapists, like, people are reading you, and they can sense this. Like, yes, we can nod our heads, and yes, we can be like, yeah, oh my God, that's got to be really difficult. But if you're being disingenuous, the clients can read that. They really can, and they will. A lot of them will call you out on that. What happened? Karina, are you there?
So I believe this is the video. Or is he at that point?
And then,
Yaritza,
yes.
are you okay?
Yeah, I'm okay. Can you still hear me?
Yeah, I can. Just let me know when you're ready for the video.
Okay. And then empathy versus apathy. So these are the clinical skills that you would be demonstrating with your client in an office, right? Like with respect, domination. We talk a lot about self-disclosure. Some people think, okay, you cannot disclose at all. And then in substance use, there is a different level of that. We often think, hey, if somebody is in recovery and you're a clinician that's in recovery and you can share something that's going to benefit the client, then that's when you would share it with limitations and boundaries. So it's learning some of those things. I often tell my therapists, if you are sharing because it's benefiting you or there's a strong emotion connected to it, then that probably is telling you that you're not doing the work and that you are benefiting from disclosure versus benefiting the client. And so it no longer becomes a skill and it becomes a domination. Another one is empathy versus apathy. This field has a high burnout rate, and typically within 5 years, therapists are actually leaving the field, which is very interesting, and doing other things with their licensure and their skills. And so the empathy and apathy part is like, when do you figure out that you're starting to burn out? When is it that you realize that you need that break? And what I can say to you is if you're seeing that your skills are becoming non-therapeutic and that balance is really being outweighed, then that's when you know, okay, am I really benefiting the client? Is this rapport going to be established? And that's when we know we need a break. So the clinical skills that we do use, we often reviewed these in grad school. So enhancing the relationship and alliance by active listening. We're going to talk a little bit about active listening, what that looks like. I believe there's a small clip as well for a demonstration. The difference between empathy and sympathy. Empathy is like, hey, this sucks. Like, this really sucks. I'm here with you. Versus sympathy is like, oh, that does suck, and it sucks to be you. So it's just being mindful of the difference between empathy and, I tell people, my clinicians, empathy is aligning with that client, right? It's feeling with them what they're going through. It's validating that experience. Sympathy is standing from a different point of view, pointing the finger, saying, I'm glad I'm not there, but I know it's tough. And then unconditional positive regard, that is that level of support, non-judgmental stance, and genuineness. So that's what I did. Okay. So I'm just going to go back a little bit because I see where I missed that video. So I think it was right here on the Therapeutic Alliance. And Eric, if you want to go ahead and play that, I think I jumped over it, so I apologize.
Karina will get that going for you.
All right, thank you.
Mm-hmm.
So what is active listening? One of the things that I find interesting about active listening is that when we hear the word, we think that it's a pretty easy concept. But what I can say is that it's an art, and it's something that I believe is a gift that can be developed into a skill, that which most of us really struggle to have. So I have a short video. We're going to review some of what I believe active listening is, but I will often tell my clinicians it's the ability to respond and not react, and to fully and clearly hear what somebody's saying. Because studies show it's usually like 20 or 30% of what we actually get from what people are saying. And most of us, until we learn to really how to effectively communicate, will listen to react versus respond. So the therapeutic relationships begins with the ability to actively listen. Listening is one of the most important skills a therapist can demonstrate. And how well you listen has a major impact on the quality of your relationship with the individual. Research suggests we only remember between 25 and 50% of what we hear, as described by Edgar Dale's cone of experience. So again, and I often say, like, listening isn't just listening. Like, you listen with the way your body responds, you listen by the way your head nods, you listen by the way that your facial features are, and then you listen by summarizing. And we'll continue to read that. So how to actively listen. You're trying to understand feeling contained in what the individual is saying, not just the facts, words, or ideas. This is really big for me. I had to staff a client the other day with one of my clinicians, and the client had, some work issues and wanted to step down levels of care, but was, we didn't think it was the right time. The best friend one of the good friends had relapsed and passed away. So the client's, sitting in the chair and we're talking to her, and quickly she's like, well, I want to work and I want to go, I'm going back to work full time and I want to go to the IOP level of care. And, I want to advocate that for myself. And her clinician was quick to say, well, that's not what we recommend at this time. And then the client was like, okay, sure, no problem. So the clinician was like, okay, great. And so I paused for a second and I'm like, okay, I hear what you're saying, that, this is your recommendation. I said, but I'm struggling with that. She's trying to work full time, do 6 hours of outpatient program, and I'm trying to figure out how that can align with benefiting her treatment, because let's be honest, that's not going to be a good balance in her life. And then I'm also struggling with her inability to stick to her boundaries, to, because she presented this, as soon as the clinician said that, she was quick to change her mind. And so I'm wondering, like, all right, so here's somebody that's quick to please, and so, like, I heard so many different things above what's being said. And I could see her in her seat just kind of slouching down when we said it, but was like, okay. So, her body language is communicating a lot of things. And also, like, I'm looking at things like her life is going to be unbalanced. She's advocating, and even though it might not be recommended at this time, like, she's got to be mindful of her boundaries and communicate what's best for her. So again, it's not just what the client is stating, but it's learning how to listen and try to really listen to the feeling that's being contained. Of course, making good eye contact, your body language, the nodding of the head, mirroring the individual's body language is important. Are their arms crossed? What are you telling me if your arms are crossed? I had a client the other day that was being staffed because there was new youth, and he was an outpatient level of care, and he comes in and sits in his chair, and he crosses his arms, and, he puts them up by his chest, and I'm like, oh, okay, so I get it, he's guarded. Am I going to mirror that language? No, I'm not going to mirror that language. And because I want the client to feel open and ability to communicate. By the time he left, he admitted his use, he was struggling, he wanted to come back to detox, his arms were down by his side, his shoulders were a little less tense. So it's just being aware of all of that, because it's a lot more than what a client says. Saying yes occasionally, correct posture. What are you telling your client? And of course, this is another skill most of us learn in grad school. It's paraphrasing, summarizing. It helps to confirm what the individual is saying and to help them feel heard. Summarizing involves proposing and then verifying your overall impression, not unilaterally imposing your perception of the individual story. So this is, if we're paraphrasing, if we're summarizing, be mindful of your own opinion of that. Stick to what the client is stating, right? So if the client's like, oh, yeah, that was really difficult for me. Well, oh, yeah, I can see that you're being frustrated. Well, that's not summarizing. So I often tell my clinicians, be mindful of you imposing your own assumptions of how the clients feel. You want to validate that first. So how to actively listen. This is a quick video of interpreting body language. So the clinical skills, will continue on that. Nonverbals. Much is communicated that is not verbalized. Even when an individual is not talking, the individual is still communicating in some manner. So again, I want to reinforce the importance of being aware of your own body language in the session, how you're responding, what your body's communicating. We'll often, talk about when people constantly look angry or upset, or hey, why don't you smile? Those types of statements that you can hear. So it's very important to understand, what people are perceiving and assuming about how we're feeling. The skilled listener hears more than the speaker's voice. So pitch, tone, subtle variations. So for example, pitch is a big one in your tone. So if I start saying face, color, how it changes, there's a pitch and tone, and instinctively we are taught to listen to that, to the pitch and tones. So being mindful of those, how those are being communicated. Again, we talked about face color and how it changes, your movement of lips, your mouth, your eyebrows. Become aware of expressions that convey tension, doubt, the burning eyebrows or furrowing eyebrows when they come down, or especially when we're being inquisitive, trust and attention. All right, so I'm just going to acknowledge a question here real quick. Somebody asked, what tips might you have for telecounseling and or video counseling? So, Ron, can you be just a little more specific in your question as far as tips? Do you mean like how do you align with somebody in that? Because if you're doing, telehealth is what I call it, and video counseling, that definitely has some different types of challenges. But again, I still think that you are communicating in the same manners. Right now, all of my outpatient services, PHP and IOP, are telehealth. So as clinicians, we all took a training as well on telehealth, how to effectively do that, how to effectively communicate. And what I have learned through that is that's also so individualized. I've had great people really enjoy it via telehealth, and other people say, like, I really need that person-to-person connection. So it's definitely not a fit. It's not a fit for everyone, and I explore that with people, especially the ones that struggle with social anxieties and having to see themselves on the telehealth is struggling, or watching so many people on the screen, including yourself, creates, believe it or not, a lot of social anxiety for some of our clients. And so because they're not able to establish that community together in the PHP setting before getting on the telehealth, it can be challenging for sure. But one of the things he's asking is alignment would be a start. And I think, again, the kind of atmosphere, the kind of warmth, aligning in the sense of finding a common ground, talking about the challenges to tell, hey, tell me a little bit of how is it? How are you feeling through this? Open communication is key. And so for me, I'd be like, tell me how this experience is for you. Hey, let me know what your initial thoughts of telehealth were. What are some of the challenges that you see? Is a good place to start. So how not to listen, and I think we talked about this, and the scenario we already saw is, what is this person saying? What is he communicating, right? There's no words in this picture, and you can definitely see that he's communicating, I don't want to listen, or maybe this is making me upset. I'm not really sure what you're trying to say. So it's interesting that this picture here can say 1,000 words without saying one. So what is empathy? Taking the perspective of another by seeing situations from their point of view. Being non-judgmental, key. Tuning into and understanding another's feelings and communicating that you understand and care. And I believe we have one short clip here that Brene Brown does an amazing job. She's amazing. Love her. If anybody isn't aware of Brene Brown, I would say take a look at some of her stuff. It's great. But So why is empathy so important? And I do believe that empathy is one of the most, and of course this is just my own personal perspective, if not the most important clinical skill that you can have. I mean, it really leads to strong therapeutic alliances. A client feels understood, they feel heard, they feel valued. And so, if a client is in shame, they've done something that they, compromises their values and they're struggling, how nice is it to have somebody say, hey, man, I know that's gotta be so difficult. I can't imagine what's that like. So I'll give you guys an example. It's really interesting because I think that our values and our morals really need to be understood so that we don't project them into our therapeutic sessions. So I often hear many clinicians say, I could not deal with a child molester, or that would be really difficult for me, for somebody that would abuse. That takes, I don't know how people can do that. It takes a special person and so forth. And I had a client once, and he was a veteran, and I treated him for 90 days. And so we were 60, 70 days in, and a lot of distorted ways of thinking, a little on the paranoid side, PTSD, went to war to try to die and wasn't successful. Just a lot of complex trauma in childhood. And so we talked a little bit, and what I noticed is around like the 70th day, I saw change. Like it was almost like, okay, and he kept saying to me, like, I need to go to a church so I can talk to a priest. I need to go to a church so I can talk to a priest. And I'm thinking, like, the spiritual component, 12-step principle, it's important. So I was trying to get to that, but it became such a focus. And when I hear things a few times, I'm wondering, okay, like something's pressing, and I'm noticing that there's no continued progress in his treatment. And so finally I said, hey, I keep hearing you say this. So I just, want to hear, like, is there something that you're struggling to share, or something that, you really feel, what's going on? Like, what do you think is getting in the way? And he's like, oh my God, I can't tell you. I need to get this off my chest. And then I'm like, oh, okay. I'm like, well, I just want you to know that I understand, and I know that things can be difficult. And if this is something that you want to process, just know that, I'm here. I'm here for non-judgment. I'm here to support and continue to be your biggest cheerleader. And so finally he says at the age of 13 that he, touched a child inappropriately. And this is somebody that I had a relationship now, and we had a strong therapeutic bond in his progress. And so it was so important for me at that time because, yeah, I had the thought, maybe I can't treat this population. But what I came to realize is that he was also broken, needed somebody to have empathy for him and to take that non-judgmental stance. And so we really did some good work in there. But again, if it wasn't for me being mindful of that empathy, my own values and judgments, how would that have gotten in the way of somebody that was progressing so well? And, how could have that hurt the therapeutic alliance? So communication with empathy yields empathetic communication, which leads to a trusting relationship. If I can tell you guys a change that I saw once he was able, to let that demon out of his closet, and his ability to be free, it was powerful, very powerful. Trust and feeling of being understood reinforces that relationship so the individual feels they are being heard and respected for their unique experiences. Empathy is a substantial predictor of the individual's outcome in psychotherapy that holds across theoretical orientations, treatment formats, and the individual problem. So the empathy, again, is one of the first clinical skills you learn, most of us in grad school. It doesn't matter which one. I mean, psychoanalytic is a little different for the most part, but I would say overall, most of them, if not all of them, stress the importance of empathy. This finding has been proven in many research studies and in multiple meta-analyses. Empathy is not only something that is provided by the therapist, as if we're a medication, but it is a co-created experience between a therapist trying to understand the individual and the individual trying to communicate the therapist and be understood. The idea is to be empathetically attuned to the individual's experience as opposed to their own words or content. Empathic therapists do not simply recite the individual's words back to them, but they understand their goals, tasks, their moment-to-moment experiences in a session, and their unspoken nuances and implications. Sorry, my email's in the background. Empathic responses require therapists to continually adjust their assumptions and understandings, attending to the individual's experience to facilitate awareness of emerging feelings and perspectives and be mindful of their morals and values. So again, we can have in mind this is a population that I like to treat. This is this is a population that I'm most empathic towards. So much more can come out of those sessions that we don't plan or know, and some of the people's deepest, darkest secrets. So we really need to be mindful of our own values and judgments and morals. Empathy entails individualizing responses to the person you are serving. There is certain diversity in the empathy outcome associating, pointing to the value of personalization and clinical judgment. Empathy will probably not prove effective unless it is grounded in authentic caring for the individual. Encourage psychotherapists to value empathy as both an ingredient of a healthy therapeutic relationship as well as specific, effective response that promotes strengthening of the self and deeper exploration. So empathy is not trying to help somebody solve a problem. I know most of us can, or I can speak for myself, I can jump into that at times where I'm like, oh my God, I know what I can do or I can help. But that's not what that person needs. They just need something to feel heard and understood. So empathy is not solving a problem. It's just aligning with your client to say, hey, this really sucks. And sometimes I don't even know what to say. I'm here with you and we can, get through this together. Okay, video. So empathy promotes a connection. Sympathy promotes isolation. Empathy, I feel with you. Sympathy, I feel for you. Empathy is walking in their shoes and truly understanding their pain. Sympathy is feeling bad for somebody's pain, right? Empathy is understanding and acceptance are revoked under empathy, and with sympathy, it's more pity, sorrow, and concerns are revoked. And this cute quote that I like is, empathy is walking around somebody else's moccasins, and sympathy is feeling sorry their feet hurt. All right. So, Karina, if you want, we can take that break now. It's 11 o'clock before we move on to unconditional positive regard.
Yes, that'll be great. If you want to take a break and be back at 11:05, that would be awesome. Thank you. Yaritza?
Yes, ma'am.
Yaritza?
Yes, ma'am. I'm here. Karina?
Can you hear me?
I can.
I was able to get the other two videos.
Okay.
So if you want to just prompt me whenever you're ready for them.
Oh, thank you. That would be great. Yes, and
Okay, thank you.
yeah, because we're making some, we have some good time still left, but we do have quite a bit of slides. So I was even thinking, okay, I was just making sure. So yeah, I'll definitely give you the prompt. I think it's easier that way when I can prompt because I can feel like when it's a good point to put it in. So that works.
Yaritza, are you ready to get started? Yaritza?
Yes, ma'am, I'm here.
Okay, I'd like to welcome everyone back, and I'll turn it back over to you, Yaritza.
Okay, perfect. So does anybody have any questions thus far? So what is unconditional positive regard? It's the good old Carl Rogers that most of us are familiar with. Carl Rogers' theory is based on unconditional positive regard. And it's the respect one has for another person, but it's obviously going to go a lot deeper than that. An understanding of no matter how dangerous or dysfunctional they may appear to be, the individual is doing his or her best. So DBT also has this skill that they talk about where accepting the client where they're at, we often hear those things, and then to have an understanding that this is where they are and they are doing their best. Respecting one's right to self-determination, expressing appreciation of the individual as a unique and worthwhile person, protect individuals' revelations from personal biases, reject or disdain regardless of discussion's content, provide acceptance regardless of discussion. And that goes back to empathy that we talked about is just, sometimes we're going to hear things that don't align with our own values, and understanding like how do we continue to accept, to not be biased, and to provide unconditional positive regard. So here, just like we just spoke about, respect of individual regardless of difference of values or worldview. No condition is set up upon the individual's behaviors and experiences, and non-judgmental mindset. So in my supervision, I'll say things like, okay, what are the client's goals? I'll often hear the clinician say, my treatment plan. I'm like, so how did the client contribute to this treatment plan? What is their treatment plan? Because we all have different ways that we measure success. We all have different ways that we measure goals or what those goals need to be versus, the clinician has a thought, well, this should be a goal, right? This should be a goal versus what the client wants it to be a goal. What's the client's success? I had a clinician had a schizophrenic client come in, and I look at the treatment plan, and there was just extensive amounts of like getting a job, mood stabilization, interpersonal relationship improvements, and I had to sit the clinician down, and I'm like, so what part did the client have in this? And they're like, well, this is stuff that he needs to have, success. And I'm like, well, whose success is that? Sometimes the only thing that we can have the client mark as a goal, and this is something that they have to engage in, is just medication management. I mean, that's the first step. What is it the client wants to do? So again, it's like we set these conditions without even realization based on our own perceptions of what these goals should be. And it's super important to meet the client where they're at and to discuss, okay, what is your goals? What are your expected outcomes? What are you here for? What is it that you want to get out of treatment? And versus what we think the client needs. So what does respect involve? Do no harm, become committed, supporting the individual regardless of how your biases or judgments may get in the way, taking a non-judgmental stance, and keeping the individual's agenda in focus. Meta-analysis have indicated that positive regard has a moderate association with psychotherapy outcomes, which, like many other relational factors, is a significant but not exclusive part of the clinical process outcome equation. A therapist's provision of positive regard is strongly indicated in practice as it provides the basis for other helpful interventions. Any questions on unconditional positive regard? We'll keep going. The next skill is genuineness. And when we look at all these skills, it's like they intertwine even to some extent, because in order to to be empathetic, how do you have judgment, right? So it's like when you look at genuineness, what does that look like? That's different a little bit to unconditional positive regard. And so for me, genuineness goes back to you. That goes back to your own strengths, barriers to treatment. I often ask clinicians, what work have you done in treatment? What is the client that triggers you? And they're like, what do you mean? And I'm like, everyone has somebody that triggers them, some sort of personality style, something. And when you do your own work, it's important to recognize that. Like, I know the clients that I have the ability to be best with. I know the clients that I can struggle with. And I think that we need to be open and honest and genuine about those things so that we can work through them. True genuineness is one's authenticity, defined as the ability and willingness to be one truly is toward oneself and another in a mutual relationship. Gelso and Carter 1994. So Lambert 1992 has concluded that practically all therapeutic orientation consider a therapist's genuineness as important for significant progress in psychotherapy and, in fact, fundamental in the formation of a working alliance. And the therapist's real demeanor means that the individual does not have to worry about the counselor is really like or truly thinks. Very important. So I'm going to give you guys transparency of earlier on in my career, I had a teenager that was so difficult. She was oppositional, defiant, extremely disrespectful towards her mother. And I could not build a rapport with her, and I was really struggling. And so I went to my supervisor. I'm like, can you please change her? Like, I'm not effective. She is extremely disrespectful. I'm struggling to like tolerate some of this. And funny enough, that client had gone and had asked for a different therapist as well. And for me, like I was trying to exhibit, that empathy or unconditional positive regard, but it wasn't genuine. And she really did, pick up on it. So especially teenagers have an art for picking this up. It's fascinating, in my opinion. But I will say that people overall can read this pretty good. It's effective in the relationship. It's our own self-awareness. Emotionally involved in the individual story, which goes back to empathy, the here and now interaction. Therefore, a therapist's genuineness is an inner attitude, a relational experience, and a dynamic process between the individual and the therapist. Therapists are real with their individuals without any pretense. Inner and outer experiences match, right? So again, that whole body language thing we talk about. Am I saying matching what I'm presenting? That's another way that they can read it. Express feelings and attitudes within limits, of course, and boundaries. Balance shared feelings with the impact. Be honest in helpful ways, not destructive. So earlier on, if I feel like I am doing telehealth and the client is struggling and I'm struggling, I think it's important to be honest with that. Like, hey, I'm sensing that we're struggling to like connect. Are you sensing the same thing? Or is this telehealth, difficult? Like, what's this experience been like to you? Exploring that, being open-minded, and genuine. Of course, we cannot share every thought and feeling. That's very important. And then counselors' feelings do not take precedence over individuals' feelings. And I think this goes back to us self-disclosure. What is the intention? Why do we want to self-disclose? Is that because it's benefiting us? Is that benefiting the client? And it's important to be self-aware and to take a look at some of those things. So a culturally sensitive therapeutic alliance has two core competency dimensions: counselor self-awareness and awareness of the client's unique variables and cultural diversities. So this is a big piece in the Therapeutic Alliance. I tell my clinicians often, like, even our homes are a different culture. Your family has a different culture. If you have, a Hispanic background like myself, that's a different culture. I'm originally from Massachusetts, small town, moving to Florida. Those are different culturals. So there's like cultural inside of cultural, excuse me, inside of culture. So I think being very aware and transparent, right? Like, hey, tell me a little bit about that. Like, tell me about your family systems. What does that look like? Like,
or hey, I'm born here and you're from there, like educate me a little bit. I think it's really important that we don't have all the answers and that genuineness and transparency is there, and they also be important, like, can you be effective? I had a clinician who was treating a Seminole client and he was Caucasian, and the Seminole client's like, no, I can't do it. Like, I have too many biases towards Caucasians. I'm not able to do it. And it's like, okay, what, knowing as a clinician when to tap out, when is it that culturals can get in the way of it? So I think it's important for that. I also had another clinician that was a female, and she was like, hey, based on this person's background, he's saying to me, like, it's not a good fit because of the dominant role male cultures have in their um, males have in their culture. So it's understanding that there can be cultural barriers, and that we need to be aware of what those can be, because again, it's not about us, it's about the client, right? And so if we're looking what's best for our client and how they can get the best out of treatment, does even culture or at that point play a barrier? So person-centered, ethnicity, social statuses, sexual orientation, language, tradition, morals, values, spirituality, religion, all of those things play a part. So I want to talk a little bit about non-therapeutic responses, stereotyping. We talked about random self-disclosure, agreeing and disagreeing, avoiding the power struggles in your sessions, having to be right. If a client comes in and he's like, hey, I'm really struggling with you right now. I felt like I shared this with you and you weren't even listening, right? How would that response look like? Would it be like, hey, I'm sorry that was like, what was that like for you? I apologize if I wasn't present for you. What is it that you need from me so that I can change that or be more aware of it versus becoming defensive? Personalizing is a big one. If I become defensive, then I am personalizing that. I'm saying, okay, how dare they talk to me like that? Or that person's just a jerk. I don't like the way that they reacted or responded to me. I have, in my supervision with my therapist, I'll say to them, you're not special. And, they often get that look. And what I share with them is that if a client treats others like that, or if a client talks to their parents like that, or their families, like, what about you is special that they're not going to treat you like that? We are who we are. And so we need to be mindful that if you're just meeting this client or you're having a relationship, maybe this is something that they need to work on, but it's not personally towards you. Rejecting, passing judgment, changing the topic or subject, not addressing concerns, giving advice. This is a big one too. As clinicians, this is easy for us, right? We have the answers. This is, again, going back to having the client own their own treatment plan, having the client making sure that what we look at success is not what we're trying to influence the client's success. So giving advice would be like, all right, this schizophrenic client really needs to get a job. Like, hey, buddy, I think that this job is going to benefit you. That's advice. So being mindful of that. And then unwarranted and sincere reassurance goes back to genuineness. Right. And we are going to head into motivational interviewing. Does anybody have any questions? Just go ahead and type them in the chat. I have been taking a look at it, so I will answer them as I come. Motivational interviewing. When an individual seems unmotivated to change or to take the sound advice of practitioners, it is often assumed that there's something the matter with the individual and that there's not much one can do about it. These assumptions are usually false. No person is completely unmotivated. Couldn't agree more with this statement. So my clinicians will come, I don't know what to do, this client's unmotivated. And I said, I wouldn't choose that. I would say that they're not committed to the process that you're currently in with them. You have to find what's motivated. It's not that people are unmotivated. They're not committed, and you have to find different ways to motivate them. In order to do that, you got to remove barriers. So that's a lot of what MI does. It's a collaborative, goal-oriented style of communication with attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion, designed to produce rapid, internally motivated change by mobilizing the individual's own change resources. And we're going to explore this more. Motivational interviewing is a method that providers are encouraged to use in their practice in treating substance use to facilitate change. And my training will assist the providers to enhance their clinical skills and become more efficient in them. Motivational interviewing is considered, they call it the spirit of MI more than even a modality. It's just a different way of approaching. The power in MI with the client is equal. It doesn't have any change of power differential shift. It's really just working with the client on the same page, exploring things so you can find out what motivates the client. Open-ended question. Motivational interviewing has a lot of acronyms. I'm giving you the basics. It's OARS, which stands for open-ended questions, affirmation, reflective listening, and summary reflections are the basic interaction techniques and skills that are used early and often in a motivational interviewing approach. So open-ended questions keep the conversation going. It allows individuals to process response versus answering reflectively, empowers the individual to direct the narrative. And I say be mindful of the why. And the reason why I say that is because as children, a lot of times our parents, we did something that we would get in trouble for, and our parents would say, like, why would you do that? And so it comes across as a judgment question. So there is places in therapy that absolutely is beneficial, but I just say be mindful of it. So what is the close-ended question? Do you want to come to therapy today? Yes or no? Versus, so tell me a little bit about what brought you into therapy. What made you come in? Those are the difference. Will you come next week? Or versus, hey, like, I know the session was a little difficult today. Tell me what would continue to keep coming, and tell me what makes it difficult to come. So help me understand is a big one. I often say, tell me more. All right, so tell me a little bit more. And motivational interview, it really explores that. So for example, I will say, on a scale of 1 to 10, 10 being the highest, like how much did you enjoy drinking alcohol? And they'll be like, oh, a 3. Like, I don't even enjoy it anymore. Okay, so tell me what the benefits. Well, I didn't have any. All right, well, let's think about them. Let's explore them. What were the benefits? How did it benefit you? And all right, tell me more. Tell me more. And so it's just not like I allow them to answer once or twice. I will really, really explore the benefits so they can understand, hey, why is it that I use? Well, here we are. But again, tell me more. Tell me more. Affirmations are pointing out individual strengths, validating individual experiences, respect individual as a person of worth, and understand the capacity of change and willingness to do so. So we talk about change talk, we talk about barriers, right? Like, hey, a client's there, you see them progressing, 3 months in, all of a sudden there's a block, right? So what's happening there? Like, what are the barriers to do that? And acceptance of those barriers and empathizing with them, right? Like, oh, I can see how that's really difficult at this moment. Like, what is it? What do you think that's in the way? What can we do to help you get through it? And then reflective listening reiterates what the individual is saying in the therapist vernacular, statements, not a question, and it's validating that person. Summary reflections is a little bit different where it condenses it. You know, if a client's telling a story, often this is where we use summary. Condenses the main points of what the individual is saying and allows the individual to know that they've been heard and feel understood. Karina, do you want to play that first video? So this is obviously a video on what not to do. He was giving her advice. Her body language was telling him, I am not listening. There was no validation. There was no empathy. There was no reflective, no summary, nothing. So this is obviously a video on how not to do therapy. MI uses the clinical skills to help establish therapeutic alliance and the goal the individual wants to achieve. So individual determines a treatment plan, avoid unsolicited advice, involves the best basic counseling skills, express empathy, use good nonverbal listening skills, and problem-solving partners. So MI uses scales very often. And one of the things that I like about the scales is you can see where a client is, puts themselves. So on a scale of 1 to 10, how committed are you to quit smoking today? And we'll give a 6. And then I would ask, okay, so let's talk about that a little bit and let's explore. How can we get you to a 7? And we'll talk about the barriers and then how they can remove it. And then the next thing I'll ask them is on a scale from 1 to 10, how likely are you to use this technique? How likely are you to attempt to remove the barrier? And so, the scales often help us determine, okay, this is what they're saying, but how likely are they to use it? Well, maybe that isn't the barrier. Maybe we need to go back to exploring different barriers. But they have the solutions. The client has the solution. And then before we wrap up, actually, Karina, if you could do our last video. So in that video, we were able to see how she was using reflective listening, empathy. One of the things at the end that she actually did as well that I noted was mindfulness, bringing it back to him, like, what is it that you're feeling right now? making him self-aware, which is another big piece of his experience in the here and now and at the moment, bringing it back to him and having him gain some awareness of the impact overall that this is having on him. So, okay. So in order to have compassion, we need to be able to listen, we need to be able to see, we need to care with a non-judgmental approach. And finally, a strong therapeutic alliance can give the individual you serve the tools needed to prevent a future crisis. So just a quick recap on the goal of the Therapeutic Alliance is to build a rapport that leads to desired change. An individual's resistance to change is sometimes viewed as a normal and expected part of treatment. Therapists who can aid the individuals they serve in engaging more quickly through a beneficial therapeutic alliance will increase the likelihood of positive treatment. So we talked about the studies that supported the Therapeutic Alliance. We talked about skills, empathy, genuineness, reflective listening, active listening, unconditional positive regard, and then how does MI use that? If we were to use a modality, which is MI that's often used in substance use, how would we use that? How do the scales help us to determine where the client is at? What are the barriers? How to align, validate experiences so the client can have positive treatment outcomes. That's it for me. Does anyone have any questions?
There was a question, can you speak a little bit about the difference between advice giving and psychoeducation?
Yeah, I apologize. I didn't see that. So for me, psychoeducation is based on mostly facts. If I was to talk to a client about what does a panic attack look like, then that for me would be psychoeducation. If we talked about how to use grounding skills in a panic attack, those are things that are supported by our modalities that are evidence-based. If we're going to give the client like, well, I think that you need to call your mom and I think that she can help you get through this, and then maybe you can drink like a cup of coffee or tea, something that's going to relax you. So that's like the difference, right? So the advice would be, the grounded techniques that I would explore would be something like, all right, like let's talk about your senses as you're in the middle of having anxiety. Like, what are the senses? What are your senses? What helps? What can you see? What can you hear? What can you feel? What can you touch, taste? Whatever it is that is beneficial. And then the client would say, okay, like this helps, right? Like actually, if I go and talk to my mom, then that's helpful. So the difference between those things is having the facts and the modalities to support this is how it's benefiting you if this is what gets done. But how can you do this is the key piece to exploring with the client versus telling them what they need to do. It really needs to come from the client.
Can you talk a little bit about compassion fatigue and some self-care tips?
Yeah, I sure can. So we talked a little bit about how therapists often, become exhausted, compassion fatigue. I have a therapist currently that is experiencing this. And so we talked a little bit about like what was his goals to treat his clients, right? Like what brought him initially to the practice, what was that drove him to want to treat people. And most of us in this field is because we care and we want to help people change. And we get something out of it as well, right? Helping people helps us. And so we talk about, okay, if you're there, what is it that you need? And so, almost like a clinician myself, I explore what his needs are at the moment and help them recognize it. As a clinical director, I have to be mindful of like where my clinicians are at and what they're struggling with. So like I observe it where he's like his distress tolerance is low, his, like disconnect from his clients. So what do you see? Like what are the characteristics? Disconnect from clients, a lack of engagement that's, typically not your baseline. easily frustrated with certain situations, ready to give up easily. Those are some of the things. And then like really awareness of self is so big in therapy for me personally. And so for me, it's like, where is your level of awareness with this client? Are you frustrated? Are you disconnecting it? Exploring it within yourself. What is making me disconnected? And then what do you do then, right? Of course, there's always PTO if you're able to do that. And if not, for us, there's a big skill in DBT that we talk about, balance. And so for me, it's like, what is the balance? How many hours are you putting in? And so what I do with my clinicians is I said, okay, what's our word for the year? We're all going to pick a word for you the year. And if you're, feeling compassion fatigue, if that's balance, all right, then it's going to be commitment to you, right? Commitment to balance, commitment to what you enjoy. So that how are you, and I often ask, like, how are you being poured into? We pour out all the time. What are you doing to get poured into? And being mindful of, am I constantly pouring out without being poured in? And what helps me, get that back where I can be there and present for a client? Is it time off? Is it making sure that you exercise? How's your eating? How's your sleep? It's the same things we explore with our clients. It's just bringing that awareness back to self.
Okay, we have another question. I work with human trafficking survivors. Quite often they don't want to discuss anything, so I'm in an awkward position, staring, staring at the client, unsure what to say. If the client has no issues they want to discuss, what can I do to steer the conversation?
So I've had experience working with some sexually trafficked victims, and it's so much complex trauma. I think there's a lot of contributing factors. I guess some of my questions would be like, what is your time limitations? I know when we have insurance, self-pay, whatever that can look like, we have our time limitations. Because for me, one of the biggest pieces is trust. So I actually did sex trafficking clients that were coming over the border. And so the complex trauma was so expensive. And my first approach is like, we as clinicians, again, like we want to jump in and we want to just go to the meat and potatoes. And so it's like, is that trust established? When I created my office, I made sure that I had things in my wall that somebody could connect. So interestingly enough, like I put my sports team in there, and then like I would put quotes or a picture of a place, and I just created an office where like I would get reactions almost, where I would be like, okay, like they like it, they don't like it, like how can I align? So my first question is always like, what do we have in common? I ask myself, like, what can I find in common? So tell me a little bit about yourself. Tell me what you like. Tell me what you don't like. Oh my God, yeah, I like that. And so I find the common factors first, because with sex trafficking victims especially is the trust, if they don't trust you. So it's like, I had one client, a young girl that was raped very young, and she came in my office and she wouldn't even talk. And so, I had this big treatment plan in my head, of course, of what I was going to do. And then I was like, all right, she's not even talking. So let's just see if I can draw with her. Let me see what I can do. Let me see what kind of games does she like to play. Does she like to play basketball? I ended up having to find every which way, the one way I can connect first. So I have to take my agenda out. And what's the one way that I can connect first? So then she can begin to trust me. And by the end, it was, amazing. But it's just finding those common grounds and the simplicity of it without having to like dive in, because these are people's deepest, darkest moments. And for some of us to get there, it takes a lot of rapport building.
Thank you. We had another question. How would you approach the conversation with a client that is sensitive to perceived abandonment issues, that he or she will be referred to another therapist due to the inability to develop a therapeutic alliance?
Very good question. So here we have attachment issue. My style is a direct, sensitive approach. And so for me, I often think if I'm feeling it, they're feeling it too. And so my thing, what I advise my clinicians is I walk into the sessions and, we start talking and be like, hey, like, I'm struggling. I'm struggling because my experience is that I can't help you, or we're not connecting in a way, and I'm trying to figure out what I'm doing that isn't helping us connect. So I bring it back to self-awareness in myself first, because I need to figure out what are the barriers and what is this. And then what I do is align with advocating for them and be like, listen, we have spent this amount of time, and here I am, and I'm feeling like I don't want to waste your time. And like, you're eager to get help. You're here. Something brought you here. And so for me, I have to be selfless enough to remove myself out of that equation if I'm not benefiting you. Because it's not about me. It's about the client, and you're going to be shocked sometimes. They're going to be like, no, oh my God, like, no, we are connecting. And so that's why that open communication and that genuineness is so important. Because if I'm here to help you and I am a barrier, I want to know. And then, I also want to learn, like, how could I improve this next time? Because perceived abandonment issues are so difficult to work with, and yet you might re-trigger that client, rip off the Band-Aid where they can feel like I'm not lovable. And so I would make it more about me than I would about the client.
Thank you. We have another question. How have you dealt with racial divide? Someone who wanted a white counselor versus a black counselor. What have you done to break this barrier?
This is a tough question. Okay, so I've had it in reverse, to be honest, where when I was explaining that the Seminole client didn't want to be with the white or Caucasian therapist, what I can say is that when I first meet the clients and we're assigning clients, I really try to gain a perspective on this to avoid some of these issues. But I have also, like, if I have a client that's asking me, okay, like, I am adamant that I want a Caucasian and white therapist, and I'll be like, all right, so let's explore some of that. And I'm Hispanic myself. So for me, it's like, okay, is this person going to have a barrier with me? And if that's the case, because I am going to reinforce again, yes, we all have our feelings about racism and segregation and all of those things, but this isn't about me. So if they are really advocating because culturally they connect or so forth and so on, I will express to them the limitations. I can give you a Caucasian or white therapist. I'm fine with that, but I'm not able to do that throughout my whole program. So if you're attending groups, I need you to understand, like, I'm not able to provide that service. So I would, if it's to benefit the client, I would absolutely reassign somebody, but I would explore it first to see what the limitations are, and then give them what our limitations are as well.
Thank you. You shared that 40% of success in developing a therapeutic alliance was based on extra therapeutic factors. Can you review those and share where that research is from?
So I have the link in my references. All of those would be in there. And the extra therapeutic factors I talked about was things outside of the hour. So that would look like, what would homework look like? What is the level? Like I explained, if you're like a GBT therapist, one of the things that you would do is be available 24 hours around the clock, really, with limitations and boundaries, of course. So those would be considered extra therapeutic. Cost is considered extra therapeutic. Whether you are a private pay or whether you have limitations on your insurance, those are going to be considered extra therapeutic.
Thank you. We have a comment and a question. I like the example provided about requesting to transfer the client to another therapist. This would make me feel like I'm giving up somewhat. How did you handle that professionally and mentally?
So I think it goes back to, and you've often heard me say, the barriers to treatment and how not to personalize it. I think it's so important to touch in with your clients to see where they're at in the process. How are you benefiting from our process? Where are your goals at? I often review, when you first came in, here were your goals. Okay, this is where we're at. Like, is this where you expect to be at? Is this where you want to be at? What do you want to get out of that? And you can hear in my verbiage, linguistics, that I ask a ton of questions, open-ended questions. So it's, once again, very important for me to understand is to not to be in the way Because if I take that personally, and yes, I'm not saying that our feelings aren't going to be hurt, or I'm not saying that it's not a struggle, but I have to reinforce and remember, okay, the reason why I'm here is to help this person. This isn't about me. But I can ask, what is it that you think got in the way? What was it about the relationship that you struggled with? And so it's, again, having that genuineness, open communication with your clients to get an understanding and for your opportunity to get feedback and for your own personal growth as well.
Thank you. What do you suggest trainings or techniques or interventions to help build the therapeutic alliance with children virtually?
So this isn't one that I have a lot of knowledge on, especially for children virtually. I have never done this, treated a client versus telehealth, especially a child. So I would say you would have to definitely do some research because telehealth is just so new to us at this point that there's not enough research out there. I mean, we are just starting to really unveil and roll this out. So I think it would be something that you would need to research more diligently on your own. I apologize.
Okay, what is IOP level of care?
So well, actually it could be for mental health, but we have detox for substance use, residential is inpatient, PHP is partial hospitalization placement, and what that means is 6 hours a day you see a provider versus it could either be a nurse practitioner, a psychiatrist, or and you still attend 5 days of groups, 6 hours a day, 5 to 6 hours depending, and then you have intensive outpatient, which is IOP, and that's 3 hours a day. Do not see a provider any longer. You would see an outside provider, and you would still see your therapist individually at all these levels of care weekly, but the IOP daily depends on the recommendation clinically.
Thank you. How do I approach a client who is severely depressed but uses humor as a defense mechanism?
I would actually flip it around and talk about how it's a strength. And so humor is a strength, but I would talk a little bit about how I see it as a strength, and I would approach it as how was he able to use this to get through the depression? Where does he see that it helps? Where does he see that it hinders his depression? And so when you use it as a strength, our strengths can be our biggest weaknesses. So I would explore that with them. Well, I see it as a strength. Like, man, this is awesome. I think you're so funny, and I can see how this can help you get through. And so let's explore that a little bit. How do you see it get through? From a scale of 1 to 10, where do you see it helping you get through? 6, 7, 8? And then I would talk a little bit about, all right, so let's talk about how it also helps you not, avoid, or how whatever it is, or how it contributes to your depression, And then I would honestly talk about, like, what makes it difficult to talk about the depression. I see you use humor, and it's difficult for me to kind of see where that depression is, because you're laughing and you're enjoying, you're talking about it. So, let's talk a little bit about that and what makes it difficult to talk about that. So exploring, tell me more.
Thank you. In substance use groups and during one-on-one, clients very often share behavior that they would have never done if not under the influence. Lots of both guilt and shame. Give me some language to use in these situations.
So shame is the opposite of connection. And shame is a topic that I enjoy and have enjoyed really learning about. Brene Brown does an amazing job on shame. I recommend that. But shame is the opposite of connection. So the ability to just discuss that brings light into the shame. And so I would really, really encourage clients when they start talking about that to talk about the experience, to validate the experience, to the courage of stepping into the arena is what I call it. You come into the arena, and it's not the critic who counts. It's the person that's in the ring. And so we talk about, like, that ring and the strengths and how they were able to get in there. Like, oh, my God, that was just so courageous of you to share. How, what was that experience in, like, empowering, the client and talk about, the shame and the guilt and what's the difference, right? Shame is labeling yourself that I am bad, but guilt is saying guilt's not a bad thing because guilt is a behavior. I feel guilty for doing this, but I'm not bad. So, talking and exploring is the difference between those two things, and then how you identify with shame and your ability to shed light on it provides connection, which is the opposite of shame. And then I would look in for your group, which is so important, to help them validate and appreciate the courage that it took to actually shed light on that shame, because shame is isolating. It's by itself. It's darkness.
Thank you. I had a comment and a question. Just this morning, I caught myself reverting to psychoeducation with a schizophrenic client who relapsed on Molly because he clearly wasn't committed after discussion. I backed off and met him where he was, but can you please address denial, MH, and MI?
Sorry, denial. What was the other part, Karina?
MH and MI.
This could definitely be a population that I would say has many relapses, because I think that for me personally, in order for me to even get to that point, I need to have medication stabilization. So I guess my thought back to that is like, where are they stably and mentally to even address the addiction and the relapse part piece? So my first approach to these clients is medication, stabilization, commitment to medication, barriers to those commitments, and I would work through that, because if I don't have a client being able to cognitively align or discuss based on, the psychosis or wherever that person is at in their schizophrenia, it's really difficult to cognitively process denial. I mean, are they in reality? That would be my first question.
Okay, we have what techniques help with termination planning?
I would need like a little bit more specific.
Okay, I'll give that person a chance to add some more information to their question. We do have one more question. How would you motivate a schizophrenic client who is very resistant to medication?
I would definitely do the scale approach at that point, and on a scale of 1 to 10 where the willingness may be. Because the other piece of this is, again, we have to be mindful of our intentions and what we believe is best for the client versus what they believe. So it's like, how do you motivate somebody that's not committed? We need to see how committed they are. I mean, if they're at a 0 and they're telling you no, then at that point, what can we actually do? Not much. So that's the reality of what we do, what our careers are. But I do believe I explore, what does a life worth living look like for you? That's one of my big questions. So if you think about your 8 dimensions of wellness, and emotionally, spiritually, physically, financially, personally, family, and I ask them to talk about all these components, and if they had, the miracle question, if life was perfect and you were to wake up tomorrow, where would your life be in each of one of these areas? And then I would explore, okay, you're telling me you don't want to be, med compliant, and I hear what you're saying, and, I'll validate, like, yeah, okay, I can understand they make you feel drowsy, or you don't feel like yourself, or whatever is the reason. But we talk about, like, if this is where you want your life to be, what would be some of the steps to get here? And I'm sure med compliant can be there. So that's a way, when I have, like, no motivation, is where I go, what's your life worth living? What are the barriers, and see how I can fit medication compliance in there if it truly is a barrier to get that person better or where they want to be.
Thank you. I don't see any other questions right now. Was there anything else you would like to share, Yaritza?
I think I'm good. I just wanted to say thank you.
We do appreciate your time today. You shared a wealth of knowledge with all of us, and we had so many questions and lots of interest. And again, we thank you so much for your time today.
Sure. And I thank you.
Thank you, Karina. For a couple minutes, we have some housekeeping items that we need to go through. Thank you, Yaritza.
Thank you. I appreciate it, Karina. Thank you for all your patience, and thank you all for joining. Much appreciated.
So everyone, your feedback is really important to us. So when we're done with the slides that I'm going through, you'll get a time to take an evaluation on our FADA website. If you want to receive CE credits or a statement of credit for this event, you have to complete the evaluation. You will be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. Please remember that the evaluation closes on Wednesday, the 24th. At midnight, and we do not send the statement of credit. Instead, we verify your attendance and completion of the evaluation, and the statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day. Thank you.